kicking things off with Section 1, Anatomy Basics. Okay, remember, the pancreas is a retroperitoneal organ. It's essentially divided into four main sections: the head and uncinate process, the neck, the body, and the tail. Now, the absolutely crucial thing to lock in here is the dual arterial supply. You've got the celiac trunk and the superior mesenteric artery, or SMA, both feeding it. Venous drainage, that goes straight into the portal system via the pancreaticoduodenal and splenic veins. And for the ductal anatomy, just keep in mind that the ventral ductive Wurzeln typically joins the dorsal duct right at the neck. Moving right along to Section 2, acute pancreatitis. So acute pancreatitis, roughly 80% of these cases are just interstitial edematous, meaning they're relatively mild and self-limiting. But that other 20%, those are necrotizing, which carries some really severe morbidity and mortality. What's wild here is the sheer dominance of the top two culprits, gallstones and alcoholism. Combined, they are responsible for a massive 80% of all acute pancreatitis cases in the US. The rest of the cases are a mix of things like ARCP complications, which make up about 2 to 5%, along with metabolic issues, drugs, trauma, and autoimmune factors. Clinically, your patient is going to present with epigastric pain that classically radiates straight to the back. When you're looking at labs, remember this. While both amylase and lipase spike, serum lipase is your absolute go-to. It's 95% sensitive for pancreatic disease, and honestly, it stays elevated way longer than amylase. So if you have a patient who delays coming into the ER, lipase is for sure going to give you the clearer picture. Now, to predict mortality, we historically look at the classic Ranson criteria outlined here. It evaluates a mix of admission parameters and 48-hour parameters. But here's the major clinical catch, right? You literally have to wait a full 48 hours after admission to calculate the complete score. And, that really delays your prognostic clarity. Because of that 48-hour delay, we often lean on the CT Severity Grading Index, or CTSI. This one can predict morbidity and mortality way faster because it's based purely on what you see on the scan, stuff like pancreatic necrosis, peripancreatic inflammation, and fluid collections. It allows for immediate triage, which is an absolute game changer for aggressive management. Speaking of management, this sequential algorithm is your gold standard. Step 1, aggressive volume resuscitation. You want to target a urine output of more than 0.5 mils per kilo per hour. Step 2, gastric rest. But combine that with early enteral nutrition. Definitely prioritize feeding through the gut over parenteral feeding. Step 3, hold off on the routine antibiotics. Seriously, reserve them only if an infection is confirmed or highly suspected. And Step 4, strictly delay any surgical debridement of necrosis for at least 18 to 20 days. You have to give that tissue time to properly sequester. All right, let's jump into Section 3, chronic pancreatitis. Here's a super high-yield stat you definitely need to memorize. 70% of chronic pancreatitis cases are directly caused by alcohol abuse. That's a massive proportion. Diagnosing this can be tricky because standard labs like amylase and lipase, they're often completely normal due to the progressive burnout of the gland. The cardinal symptom you're looking for is unrelenting upper mid-epigastric pain radiating to the back. You'll see that in up to 90% of patients. Functionally, the secretin stimulation test is highly sensitive and specific. On a CT scan, you'll spot ductal dilation, calcifications, and atrophy. And if you do an ERCP, it perfectly demonstrates those alternating strictures and dilations. It looks just like a string of puddles, which is why we call it the classic chain of lakes sign. So, how do we fix it? Surgery is primarily indicated for intractable pain. The Frey procedure is super common in North America. It basically cores out the diseased pancreatic head and drains the dilated ducts. Alternatively, a Whipple procedure is your choice if the disease is really isolated to the head, if the ducts are small, or crucially, if you can't definitively rule out cancer. Finally, if the disease is sitting strictly in the tail, a distal subtotal pancreatectomy is the way to go. Let's shift gears to oncology. Section 4, pancreatic ductal adenocarcinoma, or PDAC. PDAC is the heavy hitter, accounting for 90% of all pancreatic malignancies. Location-wise, 70% are in the head, 20% in the body, and 10% in the tail. The anatomical correlation with symptoms here is everything. Tumors in the head obstruct the bile duct early on, so patients present with painless jaundice, pruritus, dark urine, and pale stools. On the flip side, distal tumors don't block the bile duct early. They present late with deep pain and significant weight loss. For tumor rockers, keep your eyes out for elevated CA19-9, and remember, CEA is also bumped up in about 40 to 50% of cases. Deciding if a tumor is resectable hinges entirely on strict CT imaging criteria, specifically looking at the surrounding blood vessels. As you can see, locally resectable means clear fat planes around the celiac trunk, hepatic artery, and SMA, with zero venous abutment. Borderline resectable means there might be some venous involvement, but it's reconstructable, or the SMA abutment is 180 degrees or less. But if you see distant mets, major venous thrombosis, or full encasement of those major arteries, unfortunately, that is unresectable. Survival stats for PDAC are tough. The overall 5-year survival is a pretty dismal 6%. But, and this is a big but, successful surgical resection boosts that number up to around 20%. It's a massive difference for these patients. For the actual operations, head lesions get the classic Whipple procedure. For body and tail lesions, you're doing a distal pancreectomy, often using the RAMS technique to ensure you get those clean R0 oncologic margins. Post-op, you've got to watch out for the big 3 Whipple complications: delayed gastric emptying, pancreatic fistulas, and wound infections. Oh, an adjuvant therapy post-resection, it has a proven clear-cut survival benefit, for sure. Almost at the finish line, Section 5, cystic pancreatic diseases. Let's break down fluid collections. Timing is literally everything. If it's less than 4 weeks post-pancreatitis, it's just an acute fluid collection. But after 4 weeks, it becomes a pseudocyst, which, remember, lacks a true epithelial lining. CT is your best friend for imaging here. Now, if a pseudocyst is asymptomatic and under 6 centimeters, you can often just watch it. But if it's over 6 centimeters, sticks around longer than 6 weeks, or becomes symptomatic, you have to treat it, usually with internal drainage, like an endoscopic cystogastrostomy. Now, for true cysts, you have to distinguish between benign serous cystadenomas, or SCAs, and premalignant mucinous, or IPMN cysts. The ultimate watershed diagnostic tool here is an EUS with fluid sampling. If the CEA level comes back high, like over 192, that strongly points to a premalignant mucinous cyst that's going to need surgical evaluation. But if the CEA is low, under 5, you're likely looking at a benign SCA. Drilling down into IPMNs, these are mucin-secreting cysts hooked directly into the ductal system. Here's the rule of thumb. Main duct involvement carries up to a 50% chance of turning malignant. Because of that huge risk, it always requires resection. Side branch IPMNs are a bit more controversial. Generally, we only resect if the cyst is larger than 3 centimeters, the patient is symptomatic, or if you spot concerning mural nodules on the scan. As we wrap up this rapid revision explainer, I want to leave you with a complex surgical puzzle to chew on. Knowing those strict vascular criteria for resecting a pancreatic adenocarcinoma we just talked about, at what precise point does trying to preserve adjacent anatomy actually start jeopardizing long-term patient survival? It's a brutal balancing act, and deciding exactly when to cut and when to step back remains one of the most critical judgments a surgeon will ever make. Keep that tension in mind as you review these guidelines.